40 years old right hand dominant lady comes to the hand clinic because her right middle finger is stuck in her palm. She reports that her family physician gave her injection in that finger 6 months ago for symptoms of clicking and pain on the dorsal aspect of her proximal phalanx of the middle finger. She denies any symptoms of diabetes mellitus or rheumatoid arthritis. On physical assessment, the patient actively initiated extension of her middle finger but stopped at short arc of motion because of pain. The patient withdrew her hand when passive extension was attempted because of pain. The hand and all digits have no signs of vascular compromise. Patient 2-point sensory discrimination using a dull-pointed eye caliper applied in the longitudinal axis of the digit without blanching of the skin is within normal limits. A tender palpable nodule is noted over the palm surface of the second metacarpophalangeal joint. Anterior-posterior radiograph and this lateral radiograph reveals no osteophyte or evidence of osteoarthritis. No soft tissue mass is noted. The differential diagnosis can be a tumor mass, infection, osteoarthritis, or trigger finger. The digital flexor sheath contains 5 discrete annular bands, A1 through A5 pulleys. These pulleys prevent bowstringing of the flexor tendon and also maximizes its efficacy in relation to digital motion. Nutrition of the flexor tendon sheath is dependent on perfusion from the surrounding tenosynovium rather than the vincula system, which perfuses the flexor tendon distally through a small network of vessels. The annular band and the tenosynovium are responsible for the pathophysiology of the tendon finger and thumb. When the normal thin flexor sheath becomes inflamed and thickened, it reduces the space that the tendon has to pass through. The tendon no longer glides freely, and the tendon itself may swell up like a balloon-like mass and prevent passage of tendon through the sheath. Force movement in this point will drag the enlarged portion of the tendon, producing snapping sensations, and may lead to locking of the finger in flexion. The first annular pulley, A1, acts as a fulcrum about which the flexor tendon sheath bends. This fulcrum has been postulated as causing focal tendon degeneration with sheath thickening and tendon nodule development. When you talk about the conservative management, include modification of provocative activities in the workplace and personal hobbies, NSAIDs and COX inhibitors and steroid injections into the area of the primary pathology is indicated. Contraindication to injections or NSAID includes sensitivity to any of the material present or presence of an infection. Using a 27 gauge 1/1/4 inch needle is used to inject 1.5 cc cortisone and 1.5 cc plain marcaine or lidocaine without epinephrine into the area of the proximal flexor sheath and annular pulley. A needle should be placed at 45-degree angle to the longitudinal axis of the metacarpal at the proximal most extension of the fibrous osseous sheath, which is located just distal to the distal palmar crease. The injection should not be forced, and if excessive force is required, the needle should be repositioned. Patients are encountered to use their finger in normal fashion after the injection and should anticipate a decrease of triggering over the next 7 days. Gentle manipulation by a surgeon once the digital is anesthetized will ensure that the medication has moved proximally and distally to the fibro-osseous tunnel. A successful injection is always noted when a fluid wave can be palpated in the distal flexor crease during the injection or when a pop is felt or heard with injection of the finger. The patient attends supervised occupational therapy for around 6 weeks' time and a scheduled follow-up appointment. If triggering occurs or if the finger becomes irreducibly locked, surgical intervention is advised. Surgical management of trigger finger is performed in outpatient procedure in local anesthesia. The area over the A1 pulley is anesthetized using 3 cc of plain lidocaine solution. The limb is accentuated in and is maintained to the arm tourniquet for 250 mm at G. Surgical exposure is performed through the transverse incision in the distal palmar crease. Remember that the tendons are going through the transverse carpal ligament, so most of the longitudinal incision, if decided, will point towards the transverse carpal ligament or the carpal tunnel. Some people advocate transverse incision as well. Blunt dissection through the subcutaneous fat allow exposure of the proximal portion of the fibro-osseous sheath. A1 pulley, as well as visualization of the radial and ulnar digital neurovascular bundle which lie underneath the flexor sheath. The first elbow pulley is released through a longitudinal incision, and a small piece of pulley is excised to avoid deformation of the pulley. The distal border of the A1 pulley correlates with the anatomical landmark of metacarpophalangeal joint crease. Release of fibro-osseous sheath beyond this landmark jeopardizes the integrity of the second elbow pulley, which can lead to flexor tendon bowstringing and limitation in digital motion. Before wound closure, the patient is asked to actively extend and flex the tendon to ensure the complete release of the sheath. A dressing is applied to ensure protective dressing but maintain digital motion. Multiple triggered fingers can be a sign of flexor tenosynovitis associated with rheumatoid arthritis. In these patients with secondary trigger finger who do not respond to corticosteroid injections, flexor tenosynoviectomy is also indicated. In the rheumatoid arthritis patient, release of A1 pulley is not recommended because this enhances the biomechanical forces that are responsible for the finger deformity of rheumatoid arthritis. That is, volar subluxation of the ulnar deviation of the digit at the metacarpophalangeal joint. If flexor tenosynoviectomy does not allow unrestricted gliding within the fibro-osseous sheath, resection of a slip of a flexor digitorum superficialis tendon provide more room within the flexor sheath for the remaining slips of the superficialis and flexor digitorum profundus tendon. Complication which can happen is a nerve injury. It's one of the most common frequent surgical complications and recognized and require prompt nerve repair. The digital nerve is most often affected in the trigger thumb release, and it lays 0.16 millimeter under the skin. Another complication will be bowstringing of the flexor tendons. Release the second elbow pulley in addition to the first elbow pulley may result in loss of finger motion and an extension lag. Taking care to release only the A1 pulley prevents this debilitating complication. Scar tenderness is possibility. Recurrence is possibility. Joint stiffness can happen. And fibrous nodule formation beneath the scar is one possibility.